Good morning everyone. I will be presenting lid margin mucous membrane grafting in lid viper keratopathy. There is no conflict of interest and no financial disclosure. What is a normal lid viper? It is that part of the lid which is in contact with the globe. It extends from the mucocutaneous junction to the sulcus subtassilis and from the medial punctum to the lateral canthus. Lid margin keratinization is posterior migration of the mucocutaneous junction. This is a case of a 9-year-old male child who came with chief complaints of watering, redness and difficulty in opening eyes in ambient light for 3 months. There was history of fever with rashes, redness in both eyes, lip swelling, oral erosions, and was diagnosed as Stevens-Johnson syndrome secondary to mycoplasma infection 3 months back. The uncorrected visual acuity in right eye was 6/60 and in left eye was 6/12. The ocular examination of the right eye revealed lid margin keratinization, posterior migration of the mucocutaneous junction, atrophic meibomian glands with plugged meibomian gland orifices. Corneal vascularization was seen with corneal haze and few superficial punctate keratopathy. Ocular examination of the left eye also revealed similar findings. The clinical clues suggestive of Stevens-Johnson syndrome scored 8 out of 10. The investigations were done and the patient was mycoplasma IgG positive. The final diagnosis of both eye lid margin keratinization with lid viper keratopathy as a sequel of Stevens-Johnson syndrome secondary to mycoplasma infection was made. The patient was planned for mucous membrane grafting. The preoperative consideration were the posterior migration of the mucocutaneous junction and the lid margin keratinization and some wetness of the eye. The donor area is usually the upper and lower labial mucosa with no ulceration and fibrotic changes, and prophylactic antiseptic mouthwashes are started. The preoperative counseling is done and the procedure is generally done under general anesthesia, and throat is packed and cuff tube was used. Mucous membrane grafting was done. The donor site is the lower lip labial mucosa and the recipient site where the mucous membrane was grafted. Post-op day 7, we can see the anterior graft margin which was sutured with 60 polygalactin interlocking sutures, and the posterior graft margin was fixed with fibrin glue and BCL was applied. Graft was in situ and well opposed. According to Shanbag et al., 2/3 of the patient present more than a year after acute SJSR10, 99 without prior amniotic membrane transplantation and low vision in 60% of eyes. Lid margin keratinization causes lid-related keratopathy. If timely treated with mucous membrane grafting, it can halt the natural course of the disease and improve vision in affected eyes. The follow-up of right eye at 1 month showed a new mucocutaneous junction, the corneal vascularization which has decreased, and the SPKs which has reduced. The follow-up of left eye at 2 months revealed new mucocutaneous junction, the result corneal vascularization, fewer SPKs, and the rest of the cornea was clear. The lid viper keratopathy is a common chronic sequel of Stevens-Johnson syndrome and toxic epidermal necrolysis. Posterior migration of the mucocutaneous junction and lid margin keratinization leads to corneal epitheliopathy. Mucous membrane grafting helps form a normal mucocutaneous junction. If timely operated, it can lead to reversal of corneal vascularization and prevent corneal blindness. Thank you.
Thank you. How do you pronounce your name?
Sheel.
Sheel. Thank you.